Welcome to Pulse and Pressors, where critical care gets crystal clear. Today we are covering CALS. CALS means Cardiac Advanced Life Support. It is a resuscitation system designed specifically for patients after cardiac surgery. These patients are different from typical medical arrests. They may have new grafts, temporary pacing wires, chest drains, an open or recently closed sternum, and the after effects of cardiopulmonary bypass. Because of this, standard CLS steps can be ineffective or even harmful. CALS focuses on surgical causes, physiologic diagnosis, and fast escalation to the right mechanical support. First, the big idea behind CALS. Think physiology first. Every peri-arrest or shock state can be sorted into 4 or 5 buckets: preload, afterload, contractility, rate, and rhythm. I will define each clearly and name the matching actions. Preload means how much blood returns to the heart to fill it. After cardiac surgery, low preload often comes from bleeding or massive fluid loss. Another preload problem is tamponade. Tamponade means pressure around the heart from blood or fluid in the pericardial space. That pressure blocks filling. The fix depends on the cause. If the patient is bleeding and volume is low, give blood and fluids and control the bleeding. If tamponade is likely, open the chest quickly to evacuate the clot and relieve the pressure. In CALS, that opening is called Resternotomy. The practical target is less than 5 minutes from arrest, especially in the first 10 postoperative days, when bedside reopening is feasible and time critical. Afterload means the resistance the heart must push against. In many post-bypass patients, afterload is too low. This is Vasoplegia. The blood vessels are dilated by inflammation and do not respond well to catecholamines alone. Treat low afterload with vasopressors. Start norepinephrine. Add vasopressin early to spare catecholamines and use a different pathway. Sometimes afterload is too high. This can occur in severe hypertension or with overcorrection. High afterload can harm new grafts and the ventricle. Treat dangerous hypertension with careful vasodilation and by reducing excessive vasopressor dose. The key in CALS is balance. Enough resistance to perfuse organs, not so much that you damage the heart or grafts. Contractility means the squeezing strength of the heart muscle. After cardiopulmonary bypass, the ventricle can be stunned. Ischemia or right ventricular failure can also cause poor squeeze. Support contractility with inotropes. Use Dobutamine for inotropic support with minimal afterload effect. Use low-dose epinephrine if you also need some chronotropy or additional pressure. Consider Milrinone when there is right ventricular failure or pulmonary hypertension, because it reduces pulmonary vascular resistance. If these measures fail to restore forward flow, escalate to mechanical circulatory support. That means intra-aortic balloon pump or ECMO in the CALS environment. Rate and rhythm means whether the heart rate and rhythm allow effective filling and ejection. In the CTICU, many episodes that look like asystole are actually pacing problems. Always check temporary pacing wires and connections first. If ventricular fibrillation or pulseless ventricular tachycardia is present, defibrillate early. If there is a shockable rhythm, treat it. If there is a non-shockable rhythm and no response to immediate corrective steps, proceed to resternotomy within 5 minutes. Now, the CALS sequence during arrest after cardiac surgery. I will say it plainly, so a listener can visualize this step by step. Confirm unresponsiveness and absence of a meaningful pulse or perfusion. Immediately check the monitor rhythm. While doing this, verify that temporary pacing leads are connected and functioning. Many asystole events are actually disconnections. If the rhythm is ventricular fibrillation or pulseless ventricular tachycardia, defibrillate now, using standard energy for the device. If there is no response, or if tamponade or hypovolemia are likely, proceed to resternotomy within 5 minutes from the time of arrest. This time, target matters. External chest compressions through a recently closed sternum often deliver poor output and may shear new grafts. After the chest is opened, perform internal cardiac massage. This generates better forward flow and allows immediate relief of tamponade, inspection of grafts, and rapid control of bleeding. Run Vasoactive and inotropic support at the same time as CALS steps. Do not wait for return of spontaneous circulation to begin vascular tone and pump support. Start norepinephrine to raise systemic vascular resistance. Add vasopressin early in vasoplegia. Start an inotrope when contractility is low. Use dobutamine when you mainly need squeeze. Use low-dose epinephrine when you need squeeze and some chronotropy. For right-sided failure or pulmonary hypertension, consider Milrinone if blood pressure allows. Important CALS Pearl. Use titrated or low-dose epinephrine. Avoid large boluses that cause extreme hypertension. Once a reversible cause like tamponade is relieved, the blood pressure can overshoot. That can injure grafts or cause bleeding. Typical low-dose strategies include small boluses of 10 to 20 micrograms or a cautious infusion, such as 0.02 to 0.1 micrograms per kilogram per minute, adjusted to perfusion and surgical guidance. Use advanced monitoring to define the problem and track the fix. Ultrasound and hemodynamic numbers prevent guessing. Transesophageal or transthoracic echocardiography can confirm tamponade, right ventricular dilation, poor left ventricular filling, graft kinking, or air. A pulmonary artery catheter, or transpulmonary thermodilution, can quantify cardiac index and systemic vascular resistance. These numbers tell you if the problem is low flow, low resistance, or both. Remember a caution. Dynamic indices like pulse pressure variation and stroke volume variation are unreliable after bypass because chest compliance and ventilation patterns are different. Trust direct cardiac output, systemic vascular resistance, echocardiography, lactate trend, mixed venous saturation, and urine output. When drugs and CALS steps are not enough, escalate to mechanical support. In this setting, the default choices are IABP and ECMO. IABP means intra-aortic balloon pump. It inflates in diastole to improve coronary perfusion and deflates in systole to reduce afterload. It does not provide full flow, but it stabilizes the left ventricle and helps the myocardium recover. ECMO means extracorporeal membrane oxygenation. In VA-ECMO, blood is drained from the venous system, oxygenated, and returned to the arterial system. It can provide near full cardiac output and oxygenation. It is the rescue for biventricular failure, refractory shock, or combined cardiac and respiratory collapse. Why balloon pump or ECMO and not Impella during CALS escalation? The answer is speed, safety, scope, and team readiness. CALS is a minutes matter situation. Balloon pump and ECMO can be started very quickly in the CTICU or operating room, often through existing access or under direct vision after the chest is open. They are standard tools for cardiothoracic surgeons, anesthesiologists, perfusionists, and ICU nurses. Impella crosses the aortic valve and usually requires fluoroscopy or specific imaging and careful positioning. That takes time and is risky around fresh grafts and valves. It supports the left ventricle only, which is not enough when there is right ventricular failure, tamponade, or global collapse. For these reasons, in an acute CALS scenario, balloon pump and ECMO are preferred. Later, once the patient is stable, an Impella can be used for left ventricular unloading or as part of a planned hybrid strategy. But in the first minutes of a post-cardiotomy arrest, balloon pump and ECMO are the fastest and safest bridges to organ perfusion. Team roles turn chaos into choreography. Assign roles before a crisis whenever possible. The surgeon leads the chest reopening, evacuation of tamponade, graft inspection, and internal massage. The anesthesiologist manages the airway, ventilation, vasoactive titration, and echocardiography. The perfusionist primes the ECMO or cardiopulmonary bypass circuit and coordinates anticoagulation and flows. ICU nurses manage medication delivery, line access, blood products, documentation, and communication. A charge nurse or team leader manages time, announces milestones such as 2 minutes and 5 minutes, and confirms readiness for resternotomy and mechanical support. Common pitfalls and how to avoid them. First pitfall, waiting too long. If tamponade or hypovolemia is likely, do not delay resternotomy. The target is less than 5 minutes from arrest. Second pitfall, treating the monitor and not the patient. A normal-looking rhythm without perfusion is not a win. Focus on pressure, flow, and organ signs. Third pitfall, giving large epinephrine doses after relieving a reversible cause. This can spike blood pressure and injure grafts. Use titrated, low-dose epinephrine. Fourth pitfall, relying on external compressions through a fresh sternotomy closure. Internal massage is superior once the chest is open. Fifth pitfall, not calling perfusion and surgical backup early. Activate these teams immediately when the trajectory suggests refractory shock. Think of CALS as a continuum of rescue. It starts the moment blood pressure drops and perfusion falters. Begin vasoactive therapy during the evaluation. Use ultrasound and invasive numbers to decide if the main problem is preload, afterload, contractility, or rate and rhythm. If pressure and flow remain inadequate despite maximal pharmacology, escalate to balloon pump or ECMO without delay. Continue to track lactate, mixed venous saturation, urine output, mental status, and skin perfusion as real signs of success. A brief, quick reference summary you can hold in your head. 5 minutes to open the chest when arrest persists or tamponade is likely, especially in the first 10 postoperative days. Check pacing wires first. Many asystole events are disconnections. Defibrillate ventricular fibrillation, or pulseless ventricular tachycardia, early. Start norepinephrine and vasopressin for vasoplegia. Add dobutamine or low-dose epinephrine for poor squeeze. Use Milrinone when right-sided failure or pulmonary hypertension dominates, and the blood pressure can tolerate it. Titrate epinephrine carefully to avoid a dangerous surge in blood pressure after you fix the cause. If drugs and internal massage do not restore perfusion, move to balloon pump or ECMO. Closing thoughts. CALS is more than a protocol. It is a way of thinking that connects surgical readiness with precise hemodynamics. Sort the problem into preload, afterload, contractility, and rate or rhythm. Fix the cause. Protect the grafts, restore flow. Escalate early when needed. Communicate roles and time targets out loud. This is Pulse and Pressers, reflecting on the marvels of the human body. Subscribe to stay sharp.